one of the most common, if not the most common obstetrics complication, which is postpartum hemorrhage. Stay tuned for this group call live. We have, as always, Mr. Teemu Silva, straight from Finland, from his log cabin.
Yeah, I guess you could say that.
And Mr. Harrison Steed, Australia. Good day. Good. Ladies and gents, let's start with definition of postpartum hemorrhage, because what I've noticed is that there are slight variations across the world. So in the UK, according to Royal College of Obstetricians and Gynecologists, guidelines number 52, postpartum hemorrhage is loss of more than 500 ml of blood within 24 hours after the birth. And now you can subdivide postpartum hemorrhage bleeding as minor, which is between 500 to 1,000 ml, major, which is over 1,000 ml, and severe, which is between 2,000 ml upwards. Is that this pretty much the same in your countries, Mr. Steed? Mr. Silva?
So here we use the definition of greater than 500 mils in the first 24 hours following delivery, and anything greater than 24 hours up to 6 weeks is classed as secondary postpartum. I've heard of the gradings of the mild, severe, extreme, and the like, but it's, to my knowledge, is not commonly used, at least not in the pre-hospital environment. We just determine it as primary postpartum, and that's good enough for us, essentially. But it's possible in the obstetric field that they do grade it, or at least in the hospital environment they might do so.
Finland?
Yeah, same here. And also what Harrison said about the grading. So I have no idea if it's being graded in the OBGYN field, but the EMS doesn't. In addition to the 500 mil, then obviously we use like vital signs as markers for as like bleeding kind of shock or hypovolemic shock to determine our treatment pathways.
All right, cool. Harrison mentioned secondary postpartum hemorrhage, and in the UK it is the bleed that occurs between 24 hours up to 12 weeks. What is the definition of secondary postpartum hemorrhage in Finland? Do you have it?
I have no idea. Okay. I only treat patients until the A&E doors close or the delivery ward doors close. So what happens after that is a whole another thing.
Okay, all right, no worries. Guys, this estimation of the blood loss is quite important. However, let me ask you a question: how good we are in estimating of blood loss? What do you think? Are we, I mean, healthcare providers, are we good or are we not good? And I've seen Harrison saying,
It's such a difficult task, isn't it? Like the only time I felt I was quite reliable with estimating blood loss was when someone was passing large, this was actually a secondary postpartum, and they were passing large clots, and they had them all in a bag, and I could hold up the bag and go, okay, that's a solid mass of about this big. But when you've got a liquid on the ground or absorbed into some sort of fabric like a towel or a blanket, it makes it so much harder to estimate.
Absolutely, and that's what basically midwives do in this country. So they have scales, and if they want to estimate blood loss, they put whatever towel or pad or any other material on the scale, and then they get the weight and then estimate the blood loss from the weight. However, my question was not completely silly, because there are two studies, very important studies, and we will leave the link to the studies into the description to this video. And the first one is done by Serapio et al. From 2018, which states that actually healthcare providers are significantly underestimating blood loss. We are really, really crap in estimation blood loss. We tend to underestimate. Maybe it's due to this exposure we have. We can see blood quite often, so we tend to underestimate. The quite interesting thing is that female healthcare providers are worse in blood loss estimation than male providers, healthcare providers. They tend to underestimate, females tend to underestimate even more than males. The second research I want to draw your attention to is research by Phillips et al. And what Phillips and his collaborators said is that lay people tend to underestimate bleeding of female victims, and the hemorrhage were less likely to be classified as life-threatening. And why I'm saying that is, think about the person who actually gives a call, who actually calls 999 and calls us. Always assume, and that's my personal advice, always assume that this blood loss is underestimated, because that's what we tend to do. I don't know, guys, if you come across any research like that in your countries.
No, but I would say, like, from like an empirical point of view, working in the field, I do obviously I concur with the findings. I'm not going to dispute them, but I also find that if we're talking about blood loss like nosebleeds, I think patients over exaggerate the amount. So maybe there's a difference also in terms of, like, well, nosebleeds can be serious, but they're mostly minor. And then, like, actual life-threatening bleeding like PPH. So maybe people like to downplay what it's like a really bad situation. I don't know.
So that's a very interesting point you made, because in the research by Phillips, there is this they divided the bleeding into minor and major, and apparently those major bleedings are underestimated, whilst those minor bleedings, like you said, Tim, like 20-30 mils, are overestimated. Yeah, tapping the shoulder.
Okay, yeah. I think that study is very good.
Of course. Now, cool. When we know what we are talking about, the blood loss after giving the birth, and we roughly know the brackets. Now let's talk about prevalence. In this country, in the UK, at the moment is 5 to 10%, and that was a significant reduction. Well, significant, from 12% up to 2015, roughly. And if you want to know where to go for the latest data, Embrace report, that's a really good idea to have. You always may check Royal College of Obstetricians and Gynecologists website as well. But yeah, getting back to numbers, 5 to 10% up to 2017. And then it dropped to 5 to 10%. So from 12 to 5 to 10, which is good. Now, there was, however, quite interesting thing recently, like very recently, like a couple of months. What we've noticed is sudden rise in PPH incidents, and we were thinking, what's going on? And I know that there was a huge thing in obstetricians and midwives environment, lots of investigations going on, and what we found out is that, unfortunately, most likely it happened due to the unlicensed use of oxytocin. And if you will keep that in mind, I will refer to this unlicensed use of oxytocin slightly later when we will discuss management of PPH. But yeah, keeping that in mind, that unlicensed use or overdosing of oxytocin may actually send everything south, and everything can go really wrong. But that's slightly later. What about prevalence in Finland and Australia?
I believe our prevalence is about the same here. I couldn't actually get any evidence from the quick look that I had. A lot of our guidelines and documentation really highlight, particularly around sort of low-income countries, it being obviously a very, very big problem there. And it's obviously a lot less so in developed nations, where particularly maternal health care is much better. So it does still happen here. Not saying it's completely banished and that we're above it, but yeah, it's the rates of sort of 25% of all maternal deaths sort of worldwide is pretty crazy, and a lot of that coming from those low income countries.
Mr. Silver?
Yeah, I found it was a slightly older statistic from 2015 from the emergency services. And it said that postpartum hemorrhage occurred in about 10 to 15% of pre-hospital births. I couldn't find any data overall, but I found that interesting that, especially like in Finland, a pre-hospital delivery is, I would say, it's much rarer than it was in the UK when I was working there. And apparently, or probably, a lot of those deliveries are already high risk in other things as well, and they obviously occur a lot quicker. So they also apparently bleed a lot more after the delivery. So that just makes them even more scary.
What do you consider as a high risk for PPH, guys? Is that BMI, age, previous
Yeah,
PPH?
so often we're taught, patients with high BMI and typically over that sort of 35, 40 years, often more at risk. Also, like your grand multis, so people that have had, say, greater than four or five pregnancies. People have had PPH in the past as well, obviously, is going to put them at greater risk later on. And then things like anemia, but also things that are hopefully known in the sort of the antenatal care as to like the location of the actual placenta as well. If there's going to be complications around that can lead to higher risk of PPH upon delivery.
Cool. Thank you. Now, we know what we are talking about. We know how common or uncommon it is. Now let's think about actual anatomy and physiology, and I'm going to make it very, very brief and very, very simple. Not going into the much details, just to handle this pathophysiology later. So what is normal to what is not normal, and I have my visual aids here. If you think about how the blood is delivered to placenta via uterus or myometrium, you have to know that there are some small, really tiny spiral arteries, okay, and they go through the myometrial wall like this, from mom to the baby, okay, and the blood is delivered through those spinal arteries. Now, if there is a problem, most likely it will occur with those spinal arteries. Okay, so if you think about pathophysiology now, let's think why actual postpartum hemorrhage occurs. We have our 4 H's and 4 T's in ALS, right? In rhesus. There are also 4 T's. Actually, maybe even 5 in PPH, in OBSGYN world. So if you think about pathophysiology of PPH, the first T would be thrombosis, so any problems with clotting. If there is an issue with thrombosis, most likely your patient will have this PPH, and that's what will cause the biggest problem. The next T is trauma to the genital tract. Again, very simple and straightforward, nothing to basically discuss here. The next one, the third T, would be the tissue. So retained tissue either in uterus or cervix, because what we tend to do in paramedicine, we tend to forget about the cervix, we tend to think about uterus as it is, so we tend to think, yeah, there is some retained tissue, or maybe there is no retained tissue in uterus, but it's actually, apart from the uterus, there is a cervix, where retained tissue can also cause a postpartum hemorrhage. And the last one, the most common one, is tone. So muscle tone of the uterus itself. Now, if we will go back to actual spiral artery going through the myometrium through the uterus, through the muscle wall. Okay. Now, when uterus contracts, and I will try to show it to the camera, so you can guys see it. This is a spinal artery going through the muscle wall, and when the uterus contracts, look what happens to the lumen of the vessel. It is closed, right? So contracting myometrium actually closes off the artery, and placenta separates nice and easy. Now, if there is a uterine atony, if the muscle, the myometrium won't contract, the placenta will actually detach, if you like, but those spinal arteries will remain open. Okay, and that's the problem. That's where the problem is, where the blood goes through the unclosed spinal arteries. Now, I said 4 T's, but there's one more, which is toilet. Actually, the full bladder can prevent contractions of the uterus. So I know it sounds silly, but sometimes the first aid in PPH is just emptying the bladder and letting this uterus to contract. Okay, so again, 4 T's of postpartum hemorrhage is thrombosis, trauma, tissue, tone, and the last one, if you want to add 5th, is toilet. Okay, guys, does it sound okay? Do you use pretty much same acronym for pathophysiology of PPH, or maybe you have something different up there in Finland or down there in Australia?
No, this is the first I'm hearing. It's really good. It makes a lot of sense. And also, like, going back to the risk factors, like some of those become clear, like why they are risk factors, especially with the muscle tone. But yeah, I've never heard it before, but it's really good.
Mr. Speed?
I like the order that you presented them in. It's sort of roughly in the order of how they occur. Like the thrombin thrombosis in the data that I found is about sort of 1% of PPH.
That's correct.
Retained tissue, they say about 10%, trauma to 20%, and then tone being the big one at about sort of 70% of all PPH in the data that I found. And yeah, adding that 5th one is really interesting. The toilet, it's not something that we officially use in our we use the 4 T's, but it is part of our workflow, part of our guideline to guide the mother to empty her bladder, if not already done so, as like a first line management. So yeah, sort of thinking about it as the 5 T's, we often sort of go back to these. I remember at my first year lecture, you go back to your crutch, what's holding you up, and you go back to your 4 T's. We should really add that to the list, I think, and really sort of highlight that, because that is very important.
It is, isn't it? And what I want to add here, guys, it's that very recently, I would say last 2 years, maybe last year, we want to change the approach of emergency services to OBS and gynae cases, because what we tend to do, paramedics, with me being one of them, first responders, we tend to actually jump straight on the case and try to perform lots of advanced procedures and protocols and maneuvers, whilst actually let's start with basics, and let's start with simple things. And please remember, and that's to all my colleagues working pre-hospitally, please remember that this is your patient. There is a patient behind this uterus. You are so focused on management of this bleeding because you want to stop it somehow. Stop and think. There is a female patient with all her fears, with maintain or not maintain dignity, with simple things that should be done first, like ask her to empty her bladder. So this obstetric care should be less, I'm looking for the polite word, help me here, Harrison, which word you can use, like
the native English speakers
less
on the spot.
intrusive, less
Yeah,
intrusive, less intrusive, less
it needs to be a bit more delicate, I think.
delicate. Maybe that's the word.
I'm quite lucky that in the service I work for, we've actually got a number of paramedics who are dual trained as midwives as well. And you talk to them, and a lot of the ones that I know started off as paramedics and moved into midwifery. And one thing going through their training that they really notice is, us as pre-hospital clinicians, we have a certain mindset that they're our patients. We have to treat them. They've called us. We're coming in with all our bags and equipment, and we're treating. Whereas in the obstetric environment, and even when it's when paramedics and other pre-hospital providers are called, we need to sort of step back from having that sort of whole they're our patient, like up until the point that it's complicated, and we are talking about PPH here, which is obviously a complication, but up until that point, this is a normal physiological process. We need to treat them as mothers, and we need to respect that and try to be sort of hands off. I know we often like to be hands on, but up until the point that something is changing, like you just happen to be in the room during this natural physiological process. At the point at which something changes and the patient and the mother deteriorates, then she becomes a patient, and that's when you need to manage. But at the same time, you have to be very, very discreet, because it's not just the mother; there's going to be a child there as well. Sometimes multiple. There might be some family members there as well. There might be. Sometimes we're lucky enough here to have like a home birthing midwife as well, in which case, they're sometimes the better ones to go for this sort of thing, because we go to obstetric patients very, very rarely. But yeah, it's a really important point to note that perhaps more like we should always treat our patients with the utmost respect, obviously, but perhaps more than any other demographic, I think you're right that these obstetric patients, these women, these mothers, we really need to approach it very delicately, and particularly in the point that it's possibly one of the happiest moments of their life is giving birth to a child. Now they're critically unwell and facing something that is very serious. We have to approach that very very thoughtfully, I think.
Absolutely. Thank you for underlining that, because in reiterating this very, very important thing, as pre-hospital clinicians, we need to remember about our patients that it is a specificity of actual job. It's not just the bleed. There is a patient behind the bleed, so you need to think about it. But also, what Harrison said is very important about not only baby, but also family members. Because I wanted to ask you guys, because now we are moving to this management of postpartum hemorrhage. How many patients do you have there? And usually when I ask this question to my students, yeah, exactly, because they say, oh, mom and baby, yes. What about birth partner? What about, I don't know, another members of family? They, especially in terms of postpartum hemorrhage, where there is this visualization of blood coming out of the genital tract, you in a moment they may be your patients as well, so family members, next of kin, or birth partners, and so on. So what you need to remember is to look after not only mom, baby, still in utero or maybe it's out, but also family members. And make sure that they are they won't basically collapse when they will see quality of blood on the floor. But now let's move to this more paramedic-y stuff, and in a moment I will tell you why I have a balloon here and why Timu has a balloon and why Harrison has one. Yeah, we all have balloons with the ping pong balls inside, but that's in a second. So management of the postpartum hemorrhage. Now, guys, quick disclaimer on the beginning. I'm fortunate enough to teach maternity for one of the universities in the UK, and also fortunate enough to work as a faculty member for amazing charity which is called Baby Lifeline. We teach midwives newborn life support. We try to go with them through obstetric emergencies and so on, so on, so on. So I have this contact with amazing midwives, and we had a quite interesting discussion the other day when I had opportunity to teach a course to them in terms of postpartum hemorrhage and management. So what paramedics consider as a first thing in management of postpartum hemorrhage usually is uterine massage or fundal massage. Is that the same up there down there, Finland, Australia?
I think the first thing that comes to my mind is trying to get the mom to breastfeed as soon as possible, as long as the baby is healthy enough to try and latch. Then maybe massage, and then oxytocin. I think that would be one, two, three.
I will tell you even more, because when I researched to this topic, actually I found out that we are so quick to put the hands on and start massaging the uterus. Midwives are going even further. They will go straight from massage of the uterus straight to bimanual compression, which is amazingly intrusive. However, the first thing, and please remember that, guys, we this conversation about doing the basics first, like emptying the bladder, is try to actually encourage mom to breastfeed, because breastfeeding is a natural and amazing way of releasing of oxytocin. And oxytocin will actually contract the uterus, so this uterine atony, where this, where is my spinal artery? Okay, somewhere there. When mom will breastfeed, most likely this will start contractions of the myometrium, and actually the myometrium will close off spinal arteries and most likely will stop bleeding. So breastfeeding. What did you say the next one is, Timo?
And then maybe the massage.
Okay, Harrison, what would you do?
Yeah, so the breastfeeding, well, I mean, the first is the oh shit, like we have to be very clear about this. Like, this is something that we go to very, very rarely. So the first management for us is going to be, yeah, so first off, we would really, sort of determine the state of the fundus, whether it's not firm or whether it is firm. And that would sort of help us to decide what the next step would be. Yeah, the breastfeeding and the emptying of the bladder is often done concurrently through our management, the way we've been taught, and then sort of moving to a fundal massage if those two previous actions were unsuccessful, and then sort of maintain, and also ensuring as well that the placenta had been delivered fully as well. You know. Going back to our
are you allowed
more full assessment?
Okay, so are you allowed to perform fundal massage or massage of the uterus with placenta in situ or not? And what's the rationale?
Not well. We're directed to avoid it. It's not a specific contraindication. It's told to avoid. With all these cases, and I mentioned in a couple of our previous episodes, some of our consultants lines that we have, and I implore that anyone listening, if they have a way to consult with other clinicians on this, then do so. So we have a specific maternal and obstetric line that we would consult. So if I'm getting dispatched to this, I've got them on the phone before I walk in the door. Say, hey, I'm expecting to go into this. So I'm just going to get this ready, and then have them coach me through it. But so they may direct something alternative, but for our own autonomy, it's to avoid the fundal massage if the placenta hasn't been delivered in full.
Okay, Timo?
We have guidelines around it. So you do what you think is best.
I love
to
Finland.
be fair, in most cases, we will have either a midwife or quite possibly an EMS doctor on scene, because they are so rare, and we have very good access to midwives to be transported to the patient from the hospital or in our doctor unit to respond to a maternal emergency. And most maternal cases that come through will get a doctor response quite automatically because they are so rare, as I said. So it's rarely the paramedic that does these things. It's most likely going to be a doctor or a midwife.
All right. Okay. Cool. So fundal massage. What next? Because fundal massage. Yeah. So that's why we have balloons. Before we will go further, I want to demonstrate you one trick about the fundal massage. And now, Harrison and Timo, if you did not blow your balloons up, please do it now. I will do it now.
Playing at home, it is very difficult to get a table tennis ball inside a balloon. So it took Timo and I a good sort of 5 minutes to work it out.
Okay.
Yeah,
now,
got it.
Now we have our balloons. Ladies and gents, inside of the balloon, you have a ping-pong ball or table tennis ball, which, as Harrison said, was extremely difficult to perform. Now imagine that this is your patient's uterus, and now what majority of clinicians do, and I will show it on my chest just to demonstrate that to the camera, because of course uterus is slightly lower. However, what majority of clinicians do, and now guys, I'm quite curious how you will massage the uterus, but majority of clinicians is doing this or this, which is not really effective. What you do, guys? How do you massage?
I'm just trying to wait to see what your because the stream's taking a little while. So I've just seen you go flat hand on the side and on the top.
That's correct. That's what happens.
So we're directed to use like a cupped hand, and then really sort of that sort of rolling motion.
Okay, so
like a circular kind of motion is what we're directed to.
Okay,
yeah.
Mr. Silva.
Yeah, it's actually the same as Harrison showed. Cupped hand and roll.
Okay, so now what I want you to do, guys, is let's start with Harrison. Try to massage your balloon as your doctor showed, and we'll see if actually the ball will jump through the end of the balloon. Anything happens?
Yeah, I can hear air coming out. It's sort of hard to do in this position. I've never had to give a fundal massage in general to a patient, but let alone in this.
Okay,
angle.
now Mr. Silva.
Well,
the ball is so small. His uterus already contracted. No, it's not coming out. It's stuck there.
Okay, so now I'll show you the different technique, which hopefully will be slightly more beneficial than technique demonstrated by you guys. You pop your hand on the top of the uterus or balloon, and you just squeeze it. Look what happens. Well, look what happens to the ball. Just squeeze it. Bosh! Mine is done. What about you guys?
I see.
Nothing's happening when I squeeze it.
Squeeze it. Gently.
Oh, yeah. Whoa, that's... I feel like the balloon's gonna pop.
No, balloon will be fine. It's just the ping pong ball that will actually pop out.
It's requiring a bit more force than I imagine I would use.
Oh.
But the premise is... Oh, there we go.
Well done, Mr. Steed. Waiting for Finland. Come on, Finland.
It's almost drowning. There we go.
Well done, Finland. Well done, Australia. Okay, so this is a technique I've been shown many months ago, but by one of the very knowledgeable obstetricians, and I use it since, and I would say it really works. What we just demonstrated. How do you find this trick, guys?
Well, it
Interesting.
was a lot
Yeah.
better than the cupped hand and rolling.
Cool. Good.
Yeah,
So,
so it's
uh-huh.
not something that I'd been shown before. That sort of really like that squeezing. What's the physiological response to it? Like why is that the preferred method?
You just activate
If
more.
if you know.
No, it's just you activate more muscle fibers. It
Okay.
mimics the natural contraction rather than this or this. Because if you think about muscle fibers of myometrium, they go over from the top down over the uterus. Does it make sense? So this motion actually mimics the physiological movement of the muscle fiber rather than anything else.
Right, right.
Cool. So, management of the PPH, because I know that our viewers already sacrificed lots of time to us. Thank you, guys. We appreciate every second you are with us. So, management is let's start with TLC, tenderness, loving care. Speak to them, calm them down, try to empty the bladder, and breastfeeding. Breastfeeding is a natural, amazing way of release of oxytocin, which actually, just to remind you, oxytocin should cause this uterine contraction and closing of the spinal arteries. Then, if that doesn't work, you may try Fundal massage. Now, I want to quickly touch pharmacology here. What we have on drugs is a symptometrin, which is ergometrin and oxytocin in the mixture of. At hospitals, you will come across oxytocin as it is. What do you have in Australia?
We have oxytocin. It's a 10 international unit ampule. Up until recently, we didn't have a shelf-stable version of it in Australia. So at least in my service, our intensive care paramedics, they had fridges in the ambulance, in all their ambulances. So they had oxytocin, but not all of the ALS ambulances had them. So we actually had misoprostol. But yeah, so we use oxytocin. I just want to rewind. Previously, you said that you're using oxytocin prior to fundal massage. Is that correct?
So yeah, there is one of the many approaches to prevention of PPH is giving uterotonics prior, but no one actually, there is no robust evidence, let me say that. If there is something very new and our viewers are aware of it, please let us know in the comments below, but I'm not aware of any robust evidence that would back this protocol, let's say.
Excuse me.
Bless you.
And what's your dosing that you're using as well? Is it just 10? Like
Yeah.
we're using 10 and then a repeat of 10.
Yeah, and
five minutes later if we needed.
That's correct. And what I wanted to say is actually very good that you mentioned that, because it gives me opportunity to get back to this sudden rise in the number of PPHs or cases of PPH in the United Kingdom. And thanks to Molly Midwife, who actually tweeted the whole thing, put the whole thing on Twitter. Molly, thank you. I absolutely adore you. So what happened was that quite recently we've noticed sudden rise in PPH cases in the UK, and we were curious what happened, and there was lots of investigation going on. And what we found out is that actually this sudden rise of PPH was caused by unlicensed use of oxytocin at hospitals. So two most important things, and I have it noted here, is oxytocin was administered instead of symptometrin, and it was given 10 international units IM in the third stage of labor instead of 1 ml of symptometrin. And most likely, and that's just a suggestion from the presentation I've seen recently, the suggestion was that it was done due to the economic reasons, because symptometrin is more expensive than oxytocin. The second one, and I think that was more important one, was giving 40 units of synthetic oxytocin in 500 mils of sodium chloride instead of 20 units as licensed. So basically what we were doing, we were giving too much oxytocin to manage PPH. Okay, so we thought, oh, she's bleeding, so we need to give oxytocin to contract the uterus. Oh, it doesn't work, so let's give more and more and more. Now, this overdosing of oxytocin causes desensitization of oxytocin receptors. So basically, your body or your patient's body stops reacting to oxytocin. It's just this, desensitization. I think that's the proper word. But PPH was progressing, and PPH was progressing and progressing. So, yeah, symptometrin is a really good drug. Apparently, there's one more research, and I will find out it in a sec. Oh, that is Smith et al. 2020 research that actually states that oxytocin should be the drug of choice in PPH. I think that at least in this country, it will take slightly more time than anywhere else in the world to actually change the thinking, because oxytocin, if not overdosed, is really good. So I would concur with the findings of the study. However, at the moment we use symptometrin. We tend to use misoprostol. That's how it's pronounced. Finland. You've been so quiet recently. What do you give for PPH? Pharmacology.
Symptometrin or syntokinone, I think, is the brand name that we use, but that's the only thing we have on our drugs.
What about TXA? And should we give it or should we not give it?
It depends, but it's up to the doctor who is responding. So that is like completely off-label use for a paramedic. I could suggest it to the doctor. But will they give me the permission to use it? I very much doubt it.
Hold on. Let me stop you here.
I was just trying to say, you're stopping.
No, sorry. No, because I'm so shocked that you need a doctor permission to give TXA. Is it only for OBSGYN or is it?
Yes, only for OBSGYN.
Okay, makes sense then.
Then there are like on-label uses where we can use TXA or hemorrhage without the permission, and then there's some that we need permission for, and maternity is one of those.
Okay.
But it's the same for symptometrin as well. I'm not allowed to give it without a consult, so I would have to always consult the doctor first and then give symptometrin.
Okay, Harrison, you wanted to say something. Sorry, I interrupted.
Yeah. So I don't have TXA in my service, which I'm really hoping changes soon. I think there is some work behind the scenes, but there is another one of our services, service guidelines that I've got here from Queensland, and Queensland they're really in depth. They carry a broad range of interventions that they can do, and they actually do use TXA for primary postpartum hemorrhage, specifically as long as it's less than 3 hours after onset. And I was looking at a study that I've lost the name of in front of me here. Was it this one? No, it was a different one. But yeah, so that showed particularly, less than 3 hours is given the most benefit. But there's a trial going on at the moment, the WOMEN2 Trial, and I often like these trials when they come up with these names. This is a bit of a tangent of like how they manage to fit the actual title into these ones, but this one's actually really good. So it's WOMEN2, normal spelling, and it's the World Maternal Antifibrinolytic Trial, which I reckon, WO for World, Maternal, MA, and then, or M for maternal, and then AN for antifibrinolytic. I reckon they've done pretty good.
It is.
But
well done.
Yeah, it is. So that started in 2018, I think, and they're recruiting 10,000 patients. They're up to 8,835, and they're looking at the benefit of giving TXA particularly in patients with moderate or severe anemia. And as best as I can tell, I think it might even be as a prophylactic during birth to actually prevent PPH in those patients with anemia. I couldn't sort of specifically say anything, but the gist that I got from the blurb that I read of this WOMEN2 trial is they're actually giving us a prophylactic to prevent PPH in anemic patients, which will be interesting. So
that's really interesting.
I think like here TXA, but also like dry plasma, calcium concentrate, and then obviously red blood cells that we do give. They are more part of like a generalized bleeding protocol rather than the PPH specific one. So then if the doctor wants to activate all of that, red blood cells, plasma, calcium, TXA, then we do it. Otherwise we don't.
Okay. I'm just I'm just curious because if you think about, I mean, okay, let me rephrase that. TXA definitely won't do harm. It's just I want to remind you guys that the main problem of PPH, if that's actually uterine atony, so most common cause of PPH, is this open spiral artery. So if it's not closed and cut off by myometrium, what will TXA do? Not really much. Definitely it won't do harm. I'm not saying you stop giving it because it would be silly, but I would say focus on the most important, most basic maneuvers and most basic protocols. Now from TXA I want to move to bimanual compression, which is quite invasive procedure because you insert your non-dominant hand into the patient's vagina, you clench the fist just above below the cervix, and then with your dominant hand you put it on the patient's belly, tummy, and you want to actually physically cause this physical squeeze between two hands. What would you do, guys? Do you use bimanual compression? Is it out of your scope of practice? How does it look like?
I was taught how to perform it during my undergrad, and for lack of a better term, know how to do it. But it's not in our scope of practice. So
Okay.
we use external abdominal aortic compression, putting a closed fist just above the umbilicus bit to the left to sort of get that abdominal aorta, and just external compression from there is our sort of last resort. Now, I mentioned before that consulting with the Piper service, the obstetric specialist service, they can direct us to do certain procedures. So they may, I don't know if there's any examples of this occurring, but they may direct us to, if you feel comfortable, do this procedure, and they will talk you through it. So it's possible, but it's not in our protocols, at least in my service.
Okay, thank you. Mr. Silva?
Same. I've never been taught how to do it. And also I might be directed via the consult to do it, but I find that to be very, very unlikely. Just because 99% of the time at that point we would have a doctor on scene and they are trained to do it, so they would be the ones doing it.
I just want to be a devil's advocate now because I know that, again, my wonderful friends midwives, they use it, they do it quite often for PPH. It's just I want to draw your attention to transfer or transport issues here, because if you have a patient supine with a clinician who performs bimanual compression, how would you transfer them on the truck?
With great difficulty, I'd imagine.
Yeah, so there is in the UK there is one way of doing it. Okay, in field you may come across two ways, but the first way is not really safe. So what you can come across in the UK, and it's not a good way, is the patient on the stretcher and then a clinician basically sitting on the stretcher between patient's legs and maintaining bimanual compression. Why I don't like it? Because it's not safe for either patient or the person on the stretcher, because the person on the stretcher is actually not secured at all. There's no harness, there are no seat belts, nothing for this person. Now, if you think about the patient, think about clinician's hands inside of the patient, and now think about deceleration and acceleration of the truck. And even if it's driven by amazing paramedic or emergency care assistant or whoever drives, their skills are amazing, there will be always this range of movement, and this unsecured person sitting on the stretcher will cause more damage than good. So the second way, and that's the actually accepted way, and again it depends from service across in the UK. But what we can do is put the patient supine on the stretcher, and then the person who maintains bimanual compression kneels on the floor, and the clinician's shoulders are against either ambulance wall, or there's someone on the seat who can support this clinician's shoulders. Again, not ideal, but at least gives you some kind of stability. But before you will do it, make sure that your ambulance service is happy with this setup, because we don't want to put your patient or yourself in troubles.
Yeah, that would be something that would have to be taken under great consideration, I think. It's part of the reason why we don't do CPR on a moving ambulance, and if you are a service that still does that, I highly recommend you stop, because it's the intervention that you're giving is going to be less successful. As you mentioned, the acceleration deceleration forces, but B, is very, very unsafe. So you think of these patients, in a normal driving circumstance, you're not super likely to get into an accident, but your partner's driving up the front, lights and sirens most likely, because this patient's critically unwell. They've got to watch out for breaking all the road rules and going through red lights and that sort of thing outside the ambulance. And then inside the ambulance, they've got possibly a screaming patient and you in the back with someone that's critically unwell. They've got so much on their mind. The data for lights and sirens transport to hospital. So you've got one person up the front, one set of eyes. It's something like 6 or 7 times greater risk of injury to all occupants. And if you're unrestrained in the back, kneeling on the floor, with your arm inside a patient, that's one less ability. One less ability for you to brace and be properly secured. So I think, again, we don't perform that intervention. But if I did, it would probably be one where I would consider remaining on scene and having the hospital come to us, get transport of blood products, get aeromedical transport if required. Whatever is that would be something where I consider no, it's just not safe to be transported in that way.
Yeah.
Cool. Ladies and gents, so let's quickly sum up before we will jump across the ocean and see and listen what Gina, Lurie, Wendy wants to say about American way of dealing with PPH. So, quick sum up. PPH is a blood loss of more than 500 mL after giving a birth between 24 hours. From the birth to 24 hours. If that's from 24 hours to up to 12 weeks, that's secondary postpartum hemorrhage. It is one of the most common, if not the most common, obstetric emergency, with the prevalence around 10% across the world. In the developed countries. Now, your 4 T's for PPH. So 4 causes of PPH is thrombosis, trauma, tissue, and tone. So uterine atony. There is a 5th T, which is called the toilet, so full bladder, which can prevent contraction of the uterus. And now, in terms of management, you want to look at TLC, so tenderness, loving care. Calm the patient down, empty the bladder, try to ask them and encourage to breastfeed. Then you think about your fundal massage, about your uterotonics. And now, uterotonics, one more thing I came across quite recently. In the UK, as Timo knows, because he worked in this country for a couple of years, we love to shorten words, like, for example, I don't know, gynae for gynecology and stuff like that. So what we tend to do quite often, we tend to cut the word for symptometrin, saying synto. And that's very dangerous in obstetric world, because there is a second drug that actually can be confused with symptometrin, is syntocinon. Syntocinon versus symptometrin. And actually there is even a big thing on Twitter now, stop saying synto, say the full name of the drug. So either you want to give or administer symptometrin or syntocinon. Don't shorten the name of the medicine. So anyway, uterotonics like symptometrin or oxytocin, then your TXA, then you think about bimanual compression if that's feasible, if you're trained. There are some devices on the market that you can actually insert into the patient's genital tract and try to fill up the balloon with the sodium chloride and stuff like that. Or even yesterday I've seen the device that you actually insert into the patient's genital tract and create a vacuum to constrict this myometrium. I don't think that those devices will get to ambulance service soon. If so, I hope that they will be tried properly before they will be given to the clinicians. And again, guys, I know that PPH is quite rare. I know that it, to some extent, is exciting because you have to deal with this big job. But as we always promote in group call life, we always promote thinking and going to the basics, starting with the basics before you will go up to the critical care procedures. Start with the basics. Start with this breastfeeding, emptying the bladder, and before you will take the biggest guns, make sure that the basics are covered. So now, ladies and gents, before we will finish this episode, last thing is American approach. Gina Lurie Wendy from United States of America.
Hi, my name is Gina Wendy. I'm with the United States of America here in St. Louis, Missouri. Today's topic is postpartum hemorrhage. So the two companies that I currently work for, they're pretty aggressive in postpartum hemorrhage. So let's think about hemorrhage. 500 mils of fluid is considered a significant amount of fluid loss after the delivery of the. So let's think of medic math here. A can of soda is 12 ounces, which is roughly about 355 mils of fluid. So if we see roughly about a can and a half of soda of volume loss within this pregnancy, that's considered significant after the delivery of the placenta. So let's put it into perspective. A tampon and a pad can roughly, a normal regular can have 500 mils of fluid. So I would say pretty significant bleeding loss then. So let's think of invasive. Invasive would be the uterine massage. So we do the fundus uterus massage, which is above the belly button. We do not physically go inside at all. No. So with that being said, underneath the belly button is our uterus. We just delivered this baby who is about the size of a watermelon out of a vagina. So your uterus is going to be very tight and contracted. So just like at 3 a.m, whenever you have your Charlie horses and you need to massage them pretty aggressively, that's kind of like what we need to massage our top, the fundus, the uterus underneath that belly button. You're going to feel it. It's just like that Charlie horse knot. So from there, if you by chance continue to see hemorrhage, and if your facility or rules or protocols has oxytocin, amazing. It's a natural hormone. What that does is kind of relax that uterine muscle, which is very much what we need. So just like a hormone, like insulin, it's in units. So the first dose is 10 units IM. And then from there, if you continue to need to control the hemorrhage, then you insert 10 to 40 units into a 1,000 ml bag of normal saline and then titrate to effect. So if they're bleeding a lot, turn it up. If they're bleeding a little and it's more controlled, turn it down. and then continue to monitor that patient. Also think of hypovolemia. Like, we definitely want to start IVs and be aggressive with that fluid management if needed, vasopressors or epinephrine. Now, let's talk about midwives. What if a midwife is on scene and they call us? Midwives here in the United States, depending upon each state they are, they have different rules, different regulations, different things that they can do and cannot do. So when they call us, that's a bad news bears. That means something is going on. A lot of times those midwives and midwives are amazing. They've been with that patient through the whole pregnancy. So I would take them with us and listen to what they have to say, and then treat that patient according to the next steps that are needed to treat that patient and that fetus and that infant. So with that being said, please have a good day / night. Stay cool or warm wherever you are at. And thank you very much for watching. Bye.
Thank you, Gina. That was amazing. I can see that Harrison is carefully watching his balloon. Speaking of balloons, thank you so much, guys, for all the comments. We've got some comments from Australia. I'm trying to get into the Facebook now, because I've seen that we have one of our most notorious and what's the word? Most frequent viewers, PJ Puline from Australia. Hi, PJ. Thank you for being with us. What they said is that bimanual compression is within the scope of practice in South Australia, Northern Territory. And they did it several times. Well done. I did it once in my life, and that was in a hospital environment. Did you do it, guys? No, you said that it's not in your scope of practice. No. Oh, okay. And yeah, also they requested to do it again. So balloon, guys, if you have your ping pong balls inside of the balloons, or
now I'm going to get
Actually, I think my patient has given birth so many times that this has become quite easy. So if I have
okay, stop, because what PJ wants is to do this fundal massage again, but not with your hand wrapped over the top of the balloon. What they say is because you won't be able to grab the proximal aspect of the uterus, which I agree and don't really agree, but we will try. Teemu, try to do this, like yeah, and there's a squeeze. Slightly more to the back of the balloon, mate. Squeeze it with your whole hand. Yep. See, works. Okay, it looks naughty now. It looks naughty now, so.
Yeah.
I was going to shoot it that way. Oh, there it goes. Right. It went like 5 meters.
Just shooting in now. It's a bit strange.
Okay, ladies and gents.
We're getting childish.
Three grown-up clinicians from 3 different countries playing with the balloons like kids, discussing postpartum hemorrhage. Thank you so much for watching. We had amazing number of viewers live. I hope that you enjoyed this episode and you will share the video, because we're going to post the video soon on www.groupcall.uk and all over the Facebook and all over the YouTube. So if you wouldn't mind, share it and comment. We are really glad to have you on the show. Mr. Harrison Steed, Mr. Teemu Silver, and my name is Alex Hepner. Thank you so much for watching, and see you next time.